I'm the chair of the Grand Rounds Committee. Just a couple of brief announcements. Remember to receive credit for attending today's lecture. You need to fill out the Survey Monkey that came with the Grand Rounds announcement on Tuesday from Karen Lambert. We have one more Grand Rounds in this academic year next week, and that will be on Zoom. But we are planning on having Grand Rounds in person in the fall, although it will always be available on Zoom for those who are far away. If you have questions for today's speaker, please type them in the chat function and I will ask the speaker the questions at the end of her talk. Next week's Grand Rounds will be given by Becky Stoll. She is the Vice President of the Crisis and Disaster Management in Nashville, Tennessee. And the title of her talk is Developing and Implementing Zero Suicide in Mental Health Outpatient Settings, Challenging but Doable. So it's my pleasure today to introduce Dr. Katlyn Nemani. Dr. Nemani did her undergraduate work at McGill University and then went to medical school in Boston at Tufts University School of Medicine. She did do a neuropsychiatry rotation with Dr. Benjamin at UMass, which obviously had an influence on her because she ended up doing a neuropsychiatry combined residency at the New York University School of Medicine. So Dr. Nemani, you may have heard of her because she has done groundbreaking work on the relationship of schizophrenia and the immune system, and in particularly related to the COVID-19 pandemic. She had 3 publications, either as an author or a co-author on this topic in JAMA Psychiatry in 2021, 2 of which she was the first author on. And some of you may remember that at some point the CDC added schizophrenia and depression, but schizophrenia as a risk factor for COVID. And it was in large part due to Dr. Nemani's work and these publications. Dr. Nemani is currently a research assistant professor at New York University Medical Center and a clinical research psychiatrist at the Nathan Klein Institute in Orangeburg, New York. In addition to her interest in schizophrenia and the immune system, she's also interested in antipsychotics and cardiometabolic risk, as well as the psychiatric manifestations of neurologic disease. The title of her talk today is Schizophrenia and COVID-19, Lessons from a Systemic Immune Challenge. Dr. Nemani.
Okay, thank you so much for that kind introduction. And can everybody hear me okay? Okay, great. All right. So today I'll be discussing schizophrenia and COVID-19 and what we've learned in the setting of the pandemic from the so-called systemic immune challenge. Unfortunately, I have absolutely no disclosures. Here are my learning objectives. I'll be focusing on the association between schizophrenia and risk of severe COVID and what underlies this risk, including the potential role of psychotropic meds in mediating or moderating this risk. But before I dive in, I did want to acknowledge the fact that I know another COVID talk might make some people want to poke their eyes out. And I know it's easy to feel like it's the end of days between monkeypox and the recession and the war in Ukraine, et cetera. And this is all coming on the heels of the pandemic and all of the tragedy and the disruption to society that came along with it. But it's not all doom and gloom. And this is a really exciting time for science. There is an incredible amount of progress that's been made despite the pandemic, and in some cases because of the pandemic. And collaborations are happening between scientists across disciplines and geographic borders who probably never would have connected in normal times. There's been breakthrough discoveries that are going to advance the treatment of diseases beyond the COVID pandemic. If you look at mRNA vaccines, they're probably going to be used to treat cancer, cystic fibrosis, other diseases. We've discovered rogue autoantibodies that contribute to severe infection, which is a major paradigm shift in immunology. And I think psychiatry is really going to benefit from the new opportunities for interdisciplinary research with immunologists and basic scientists that come out of this. And, there's more funding for this type of research now. So I'm hopeful that some of the research I'll be discussing today will help pave the way for that. And, the future might be as bright as it is bleak. And so with that, I'll start with, this is just an overview of my talk. I'll start with a discussion of premature mortality and schizophrenia, generally speaking, the association between psychiatric diagnosis and COVID mortality, psychiatric meds and COVID-19 risk, and then I'll finish with a discussion of immune dysfunction and schizophrenia. As many of you might know, the life expectancy of people with schizophrenia is 15 to 20 years less than the general population. And this mortality gap has actually been increasing over time as the general population tends to live longer. We're not seeing this increase in longevity among patients with schizophrenia. What's driving this risk, or what's driving this premature mortality? So this was a retrospective study pre-pandemic of over 1 million patients with schizophrenia who were under 65 that was conducted between 2001 and 2007. The standardized mortality ratio is the observed number of deaths in the schizophrenia cohort compared to the number of expected deaths based on the general population, taking age, sex, and geographic region into account. There was a near 4-fold increase in death due to any cause during this time period. And among the leading causes of premature mortality were heart disease, diabetes, and cancer. And this was pretty concerning in the setting of the pandemic when we knew that these conditions were emerging as risk factors for severe infection. But one major factor that tends to get overlooked when considering causes of mortality in this population is death due to infection and pneumonia in particular. This 7-fold increase in mortality is really quite striking, and it's been observed across multiple studies in multiple countries and across time. So based on research prior to the pandemic, there were lots of different explanations for this association between schizophrenia and severe infection. These included increased prevalence of chronic medical conditions that are associated with worse infection, like cardiovascular disease, COPD, diabetes, substance use, decreased vaccination rates, increased exposure to pathogens that cause severe disease, barriers to accessing treatment, exposure to antipsychotic medications, which have been associated with increased risk of pneumonia. And generally speaking, these factors are, confounding variables. They're factors that are associated with the exposure of interest, like psychiatric diagnosis or schizophrenia, and the outcome, pneumonia or severe infection. And assessing schizophrenia as an independent risk factor for severe infection was quite difficult. But we did have reason to suspect that people with schizophrenia might be at increased risk of severe infection above and beyond these factors, possibly due to immune dysregulation inherent to the disorder. And the pandemic provided us with an opportunity to study this in a way that we've never been able to before. With so many people infected with the same virus at the same time, extensive amounts of data captured electronically, including testing and treatment and outcomes, this really allowed us to tease out the relationship between schizophrenia and risk of severe infection. And it was important for us to do this to prevent worsening disparities in health. So we sought to answer this question: is a diagnosis of schizophrenia associated with increased mortality in patients with COVID-19? We thought that mortality rates would probably be higher in this population since they tend to have higher rates of chronic conditions like heart disease, diabetes, COPD, smoking. But we were interested in seeing whether there was an increased risk associated with schizophrenia and potentially other psychiatric conditions after controlling for these confounding variables. And we used electronic medical records from NYU, which is a healthcare system that includes 4 acute care hospitals and over 200 outpatient offices, to identify patients with lab-confirmed infection who had previously established care within our system. We wanted to make sure that we were adequately capturing their medical history. And the study cohort included over 7,000 patients. About 1,000 of them had a prior diagnosis of schizophrenia, anxiety, or depression. And what we did was we compared each of these diagnostic groups to a reference group without these disorders with regards to mortality. And here's what we found. We calculated the odds of dying in each psychiatric diagnostic group compared to the control group. First, before adjusting for other risk factors. Second, after adjusting for demographic variables, including age and sex. And then third, after fully adjusting for demographics in addition to an extensive list of medical risk factors. What we found is that schizophrenia was associated with threefold increased risk of mortality before adjusting for other variables, that this risk remained similarly elevated after taking demographic variables into account, and even after adjusting for medical risk factors, which were far more common in the population. We didn't see increased risk in patients with depression and anxiety after taking these other risk factors into account. In patients with depression, we did see some increased risk of mortality just after adjusting for age and sex, but after we took other medical conditions into account, that association wasn't significant. And surprisingly, among all of the risk factors that we looked at, schizophrenia was second only to age in its strength of association with mortality. And so the results of any single center study should be interpreted with caution. But this was a consistent finding across studies, including meta-analyses like this one, which assessed the association between a variety of psychiatric disorders and COVID mortality. In these larger studies, there was increased risk of mortality that was found in association with other psychiatric disorders such as depression. Although this risk is smaller and there's a lot more heterogeneity across individual studies that have examined this. In contrast, risk associated with severe mental illness and schizophrenia in particular has been consistently associated with a substantial increase in risk. And we can just discuss this afterwards, but we don't really know why this is the case. One potential explanation is that if you think of a disorder like depression, that might be more phasic. You have periods of depression and periods of euthymia. That might be different to a disorder like schizophrenia, where if you have schizophrenia, you have schizophrenia. Your cognitive function doesn't get better in between episodes. It's sort of more of a trait illness. And so studies that might have captured patients that were in acute periods of depression or patients who had more severe depression might have found more increased risk than studies that included patients that were well treated in periods of euthymia. This is purely speculative. So when comparing risk associated with severe mental illness compared to other established risk factors like diabetes and COPD and cardiovascular disease, you can see that mortality risk associated with severe mental illness is even higher than these other conditions. This was a meta-analysis that was published in Lancet last year. So although there's less people in the general population who have severe mental illness compared to some of these more common medical conditions, the risk associated with these conditions is potentially even higher. This research did have an impact on policy. It prompted the CDC to add schizophrenia to its list of high-risk conditions in October. It helped inform European vaccine strategy to include people with severe mental illness as a priority group in many countries. And to summarize, so schizophrenia has been consistently associated with a 2 to 3-fold increase in mortality in the setting of COVID infection. This risk is not explained by comorbid medical illness, and the evidence was strong enough for the CDC to add schizophrenia to its list of highest conditions for severe COVID, which has important implications for access to vaccines and testing and treatment in people with severe mental illness. What's the mechanism that underlies this finding? This is really the million-dollar question. Risk attributable to antipsychotic medication was among several potential explanations, still is. There is some evidence to suggest that antipsychotic use is associated with increased risk of pneumonia and thromboembolism. And there was concern that atypical antipsychotics and clozapine in particular might increase susceptibility to severe infection through immunosuppression and other mechanisms. And there were a few studies that came out assessing risk of mortality associated with different medication classes, including this meta-analysis, which looked at risk associated with antipsychotics. And using data from 3 studies, they found a greater than 2-fold increase in mortality associated with antipsychotic use. But importantly, the potential effect of psychiatric diagnosis was not taken into account. And as we know, schizophrenia is associated with a similarly high similar increase in mortality risk. So what explains increased risk in this population? Is it underlying psychiatric diagnosis, or is it the treatment? Confounding by indication is a bias that's frequently encountered in observational studies of drug effects. So because the allocation of treatment is not randomized in these observational studies, and the indication for treatment might be related to the outcome, like COVID mortality, you end up with unbalanced groups that have just differences in risks that might be related to the indication for the drug rather than the drug itself. So as an example, patients with hypertension are at increased risk of stroke and are treated with blood pressure medication. And if you didn't account for underlying hypertension, the indication for a treatment, you might falsely assume that blood pressure meds are causing stroke. This is an actual quote from one of my in-laws. Confounding by indication is an even bigger problem in drugs that are not widely prescribed because the indications for their use are narrow and they're not likely to be present in comparison groups. And in the case of antipsychotics, they're often used to treat conditions that are potentially associated with worse outcomes for COVID mortality, including severe mental illness like schizophrenia and bipolar disorder, as well as psychosis in the setting of medical conditions like dementia. So this leads to the potential to find this false association between medication and outcome when it's the indication for the drug that's contributing to increased risk, and we have to try to tease this apart. To address this problem, we conducted a study where we limited the study population to adults with severe mental illness, including schizophrenia, schizoaffective disorder, and bipolar disorder, to look at the association between antipsychotic exposure and COVID mortality by comparing mortality risk in those receiving treatment to those who were not. So using the electronic medical record, we identified 464 patients with SMI who were diagnosed with COVID infection at NYU, and we divided them into 2 groups based on their medication status. I reviewed the chart of every patient who was prescribed an antipsychotic to see if there was documentation of medication noncompliance at the time of COVID diagnosis, and assigned patients with documented non-adherence to the antipsychotic-free group, which ultimately comprised 58% of the cohort. The outcome was mortality within 60 days of COVID diagnosis. And I also reviewed every chart to make sure that the deaths that we were capturing were related to COVID as opposed to unrelated. And we looked at a number of variables that might differ between patients taking antipsychotics versus those who were not, to identify potential confounders, including medical comorbidities, socioeconomic indicators, including insurance and neighborhood poverty level, underlying psychiatric diagnosis, which we grouped into schizophrenia spectrum disorders, meaning schizophrenia and schizoaffective disorder versus bipolar disorder. We looked at the number of inpatient and outpatient visits as a proxy of illness severity. We looked at duration of psychiatric illness, and the groups were surprisingly similar. There were some small differences related to age. The antipsychotic group was a few years older. Insurance type, the antipsychotic group was more likely to have public insurance, and BMI, which we controlled for in our analysis. There were more bipolar patients in the antipsychotic free group, as you might expect, so we took this into consideration in the analysis. Surprisingly, the schizophrenia subjects were evenly split between the antipsychotic group and the med-free group. And what we found is that risk of mortality was essentially equivocal in patients taking antipsychotics versus those who were not. Odds ratio of 1 doesn't get much more even than that. What we did see were differences related to age, no surprise there, and psychiatric diagnosis. Once again, we're seeing this threefold increase in risk of mortality associated with a schizophrenia spectrum disorder, but this time compared to bipolar disorder rather than controls without psychiatric illness, and that was somewhat unexpected. So to summarize, prior to the study, there were reports of increased COVID mortality associated with antipsychotic use, but these population level studies didn't take underlying psychiatric diagnosis into account, which might have led to confounding by indication. When we limited the study population to patients with serious mental illness who were infected with COVID, we found no difference in mortality among patients treated with antipsychotics compared to those who weren't. We did see increased mortality in schizophrenia compared to bipolar disorder. And taken together, this suggests that increased mortality in schizophrenia is not explained by antipsychotics and that there might be an effect of underlying psychiatric diagnosis that's playing a role. But still, antipsychotics vary widely in their mechanisms and their molecular structures. And there's other classes of medications that are commonly used to treat schizophrenia. And we wanted to take things a step further to assess whether individual medications might be associated with risk of infection or adverse outcomes. So assessing risk of infection associated with any variable you might be interested in is normally very difficult in observational studies because a lot of the, there's so much difference in environmental exposures to the virus, which could be related to things like crowded housing, use of public transportation, healthcare contact, including treatment in inpatient versus outpatient settings. And because most healthcare systems in this country are not closed loop systems where you have one electronic medical record, a patient might go to NYU one day and Sinai another day, UMass one day and MGH another day. It's difficult to ensure that we're capturing our outcomes of interest. And so to overcome these obstacles, we decided to pursue a study of patients who were hospitalized within the state psychiatric hospital system. A bit about the New York State Office of Mental Health System. So it provides treatments for adults with SMI in 18 psychiatric hospitals across the state. And as opposed to the relatively brief stay at acute care hospitals, the mean length of stay is several months to several years across these facilities. These facilities have 24/7 nursing coverage, and medication adherence is ensured through direct observation. At the beginning of the pandemic, a COVID registry was implemented and updated daily to reflect the COVID status of every patient on census. So this included test results, transfer to medical hospitals for treatment, deaths due to COVID, and PCR testing was made available for infections starting in March 2020. By May 2020, there was universal screening available to every patient. And this was on a voluntary basis, but almost everybody agreed to testing by PCR and or antibody testing. Over 93% of patients who were on census during this time, received testing. And so the system was a sort of natural laboratory of sorts. We were able to look at patients who were hospitalized throughout the first wave of the pandemic, at uniformly high risk of viral exposure within the confines of a inpatient setting. These patients were closely monitored. They had access to testing and treatment, and their outcomes were all captured in this registry. Observational research is always messy, but this is kind of as good as it gets. So we looked at COVID infection and mortality among hospitalized patients in the system with chronic psychotic disorders, including schizophrenia, schizoaffective disorder, and bipolar disorder. We limited the study population to people who were admitted prior to the pandemic and hospitalized throughout the first wave. This was the pre-vaccination era. So we identified 1,958 patients who met study criteria. We found that nearly half of patients in this cohort had evidence of lab-confirmed infection. Most of these cases were identified by antibody testing, and these patients might have had clinically silent infections or infections that were not detected by PCR. The case fatality was 3.9% in the cohort as a whole, but if you looked at patients whose infections were captured by PCR, the mortality rate was 10%. So we saw higher rates of infection in association with older age, non-white race, larger facilities, and regional hotspots. And we also saw higher risk of infection associated with medical conditions, including COPD, chronic respiratory disease in general, including asthma and COPD, diabetes, heart disease. Surprisingly, smokers actually had lower infection risk compared to non-smokers, which is a story for another day. But this is not the first study to find this. The exposure that we were interested in was medication prior to COVID testing. So at the class level, prior to adjustment, we saw a statistically significant increase in risk associated with mood stabilizers and a marginal increase associated with first-generation antipsychotics. Conversely, we saw that exposure to second-generation antipsychotics was associated with decreased infection. This forest plot shows risk of infection associated with exposure to individual medications within classes, adjusting for exposure to other medications in the model, as well as demographic and medical risk factors that were associated with infection. And what we saw is a significant decreased infection risk associated with paliperidone, risperidone, and quetiapine. And the association with paliperidone remained significant after correcting for multiple testing. We saw increased infection associated with valproic acid, which was a bit of a surprise. Importantly, we didn't see increased risk of infection in patients prescribed clozapine, which had been a major concern during the pandemic. And then we looked at risk factors for mortality among infected patients. We saw increased mortality in association with older age, diabetes, heart disease, and hypertension. So in general, risk factors for mortality generally parallel risk factors for infection. And here we looked at the association between individual meds and mortality among infected patients. This is really an exploratory analysis that we were underpowered for because of low sample size. But you can see that the direction of association was similar for meds in the infection analysis. We saw decreased mortality associated with the use of second-generation antipsychotics, increased mortality associated with valproic acid. Although these associations weren't significant, we're seeing a trend in that direction. The only significant association we saw in the unadjusted model was clozapine, with a pretty strong effect size showing decreased mortality. This didn't remain statistically significant after adjustment for other risk factors, but this was kind of a striking finding, and in some ways more relevant because looking at risk of infection in this day and age is sort of moot, where we have over half of the US population that's been infected, and we have a population that's at very high risk of viral exposure. What we really want to know is who's going to get really sick when they get infected. So I think it's important to look at not only risk of infection, but risk of mortality. And in general, we can see that these these risk factors tend to parallel each other, but sometimes we have more power to look at this when we're assessing infection as opposed to mortality. And with regards to mechanisms, I can only speculate. Our results need to be replicated, but these are a few types of mechanisms to consider when assessing how a medication might influence risk of infection. This is not an exclusive list. The drug might have antiviral effects, like interfering with viral genome replication or release. It could modulate the host immune response, which might impact early viral clearance or inflammation later in the stages of infection. And in observational research, there's always the possibility that there's unmeasured differences between your exposed and unexposed group, which could generate a biased association that doesn't reflect a true medication effect. In terms of antiviral effects, we saw decreased infection associated with paliperidone. And interestingly, there was an in silico analysis that identified paliperidone as one of the leading drugs to bind critical enzymes that are needed for viral replication and processing. But generally speaking, I think if direct antiviral effects were playing a major role in this, we would have expected to see a protective association with first generation antipsychotics, because in vitro studies have shown that first generation antipsychotics, Haldol in particular, but not second generation antipsychotics, interact with sigma-1 receptors to reduce viral replication. And that is not what we've seen, and this is not what's been observed in other studies. That being said, what looks promising in vitro doesn't always work out in human studies. But I think that what we're seeing by and large is potentially an effect of modulation of the host immune response. So atypical antipsychotics have been shown to suppress the production of inflammatory cytokines, including interleukin-6 and TNF-alpha, which might help attenuate hyperinflammation, that so-called cytokine storm, which contributes to more severe infection. Clozapine might be unique among antipsychotics in its ability to enhance the T helper type 1 response, which has been shown to be blunted in schizophrenia. And it's also been shown to upregulate interleukin-10, which is an anti-inflammatory cytokine. And I'm not sure what to make of the increased risk that we're seeing with valproic acid. Of course, this needs to be replicated. It could be a spurious finding, but valproic acid has been shown to downregulate ACE2 in endothelial cells, and COVID enters cells through the ACE2 receptor. So it's been hypothesized that having less of these receptors available might protect against infection. However, there's kind of two phases of ACE2, and there's been several studies that have also shown that downregulation of membrane-bound ACE2 might impair immune function and contribute to poor outcomes in the setting of COVID. So jury is still out on that, and it's also possible that what we're seeing is not related to a direct medication effect, and that there's another difference between the exposed and unexposed groups that we're not capturing. This includes underlying psychopathology, so potential confounding by indication, as we discussed earlier. Valproic acid is often used to treat symptoms like mania and impulsivity, and these behavioral symptoms might interfere with patients' ability to adhere to infection prevention measures and so on. So there's many potential factors that might be at play here, and we need to take a deeper dive and replicate this in future studies to better understand it. Just an interim summary here. So we saw decreased odds of COVID infection associated with second generation antipsychotics, increased odds of COVID infection associated with Depakote, no association between clozapine and infection risk, and we observed decreased case fatality among patients treated with clozapine, although this was not statistically significant after adjustment. I wanted to take a little time to discuss our findings in context with special attention to clozapine. There were a couple of studies prior to this one that found increased risk of infection in patients treated with clozapine compared to other antipsychotics. One was in the UK using electronic records from patients receiving treatment through SLAM, which is a mental health service provider in the UK. And the other used records from the VA Medical Center in the US. As you can see, infection rates were very low in these populations. So in this UK study, there was only 102 infected patients. In the VA study, less than 1% of patients in their system had infection, at least based on what was captured in the electronic medical record. Both of these studies included inpatients and outpatients, and neither of them limited the study population to patients who were tested or took into account likelihood of testing. So patients without documented infection might have been tested and negative, or they might have never received testing at all. They both found about a 75% increased risk of infection associated with clozapine use. And two of the major limitations of these studies, which the authors acknowledged in their papers, was one, potential differences in viral exposure among clozapine-treated patients. So these patients might have more clinical visits. They might be more likely to receive treatment in inpatient settings compared to other patients where risk of viral exposure is higher. And then there's a definite potential for surveillance bias in these studies. So the more you look, the more you find. And clozapine patients might be more likely to receive testing for infections since they're monitored more closely than other patients. You know, they're often coming in for lab work anyway to monitor their CBCs and so on. So you might be more likely to test them when they come in, as opposed to other patients who might not be seen as often and who might be advised to stay home when they're symptomatic. In our Office of Mental Health study, all of the patients were psychiatrically hospitalized throughout the study period. So this limited differences in viral exposure that might differ in community-treated patients. And 94% of our patients admitted during the study period received testing, which makes surveillance bias less likely. So based on the evidence that we have to date, it seems that in an inpatient setting where risk of exposure is uniformly high for all patients, and there's close clinical monitoring and testing is easily available, clozapine may not be associated with increased infection risk. And with regards to clozapine and mortality, there's been no study to report increased mortality among clozapine-treated patients. The same British group that reported that increased infection in clozapine-treated patients assessed mortality and a number of adverse events following infection in clozapine-treated patients compared to patients treated with other antipsychotics, and they found no increased risk associated with clozapine. And the case fatality was actually lower in the clozapine group, although this was not statistically significant. The study was only 150 patients. Lower risk of moderate to severe infection has been reported in clozapine compared to other antipsychotics and some other small studies. Our study, which included 341 clozapine-treated patients with infection, was the largest one to date. We observed lower case fatality in the clozapine-treated patients, but we really need larger sample size and more research to determine whether there's a true protective effect here and what the mechanism might be. So based on the evidence that we have so far, clinicians should feel reassured about continuing clozapine prescribing in the setting of the pandemic, but it should also be noted that closer monitoring of clozapine levels is warranted in lots of circumstances in which clozapine levels are expected to increase. So this includes in the setting of infection. This isn't just with COVID, but it's with any systemic inflammation, because inflammatory cytokines inhibit Psych1A2, which is needed to metabolize clozapine. So it's been suggested that a dose reduction of up to 50% should be considered in circumstances where a patient is diagnosed with COVID and they are showing signs of systemic inflammation like high fever, or high CRP. And more recently, it's been found that clozapine levels increase after vaccination as well, particularly after the second dose of mRNA vaccines. This increase isn't usually clinically significant. It's rarely toxic. Vaccination is still safe. But for patients who are at the higher end of the therapeutic range, you might consider closer monitoring because they might get bumped up a little bit after vaccination. And lastly, treatment with Paxlovid, which is an antiviral. It's a combination of ritonavir and another antiviral, which I can't remember right now. It's prescribed for patients who are at high risk of severe COVID. You might consider an alternative to treatment in patients who are receiving clozapine as opposed to this medication because of the drug-drug interaction here. Paxlovid is known to increase clozapine levels through inhibition of CYP3A4. But if Paxlovid is used, you should check a clozapine level before and after the first dose and adjust accordingly for the 5-day regimen. And a lot of times clozapine levels take a while to come back. Like, I know for us, it's often a week or longer. So you might also consider just empirically reducing the dose by 1/3 while you're waiting for that clozapine level to come back, and then titrating your dosing accordingly. Again, less of an issue in patients who are in the sort of mid-therapeutic range, but something to really take into consideration for patients who are at the higher end of that range. Okay, so now getting to the interesting part. If the 3-fold increased risk of mortality in schizophrenia isn't fully explained by comorbid medical conditions, and it's not explained by antipsychotic treatment, what explains it? And could it be immune dysfunction? It's possible that vulnerability to severe infection is etiologically related to schizophrenia. So there's so much circumstantial evidence linking schizophrenia to abnormal immune function. If you look at genome-wide association studies, the most consistent finding has been variation in the MHC complex on chromosome 6. If you look at their first-degree family members, they're at increased risk of autoimmune disease. If you look at schizophrenia patients themselves, they're at increased risk of autoimmune disease and also severe infection before and after their psychiatric diagnosis. And one of the best models for schizophrenia that we really have is this maternal immune activation model, where individuals who might be genetically predisposed to schizophrenia are exposed to maternal viral infection during early fetal life. And this may interfere with normal brain development, moderated through the mother's immune response. And from animal studies, we've seen that it might not be exposure to a particular virus, but it's really the mother's immune response to the virus that determines risk. And prenatal exposure to early inflammatory responses might cause a priming of immune reactions, leading to a more vigorous or atypical response to later environmental challenges in adolescence and adulthood, which contributes to more severe infection. So this early life exposure to immune activation in a susceptible individual can shape the immune response for long beyond the beyond early life, and can also impact brain development. It's been associated with diseases such as schizophrenia and autism. The timing of this event seems to really play a role. So infection during the early in the second trimester seems to be the most potentially detrimental. This is when microglia are migrating, and I don't really have enough time to get into all of the interesting parts of this theory, but just to say that immune dysfunction and schizophrenia might be very intimately linked from an early stage of life. These are a few of the pathological immune responses that have been found in patients with severe COVID and have also been described in schizophrenia. The first arm of the immune response of the immune system is the innate immune system, which is our first line of defense. And it consists of natural killer cells, acute phase proteins, the complement cascade, among other components. The second arm of the immune system is the adaptive immune system, which is a bit more sophisticated. It acts on memory, includes T cells and B cells. The type 1 T helper cells produce activating cytokines. The Th2 system promotes antibody-mediated immune responses. And a shift in the balance of these cells towards an overactive Th2 response has been reported in severe COVID and schizophrenia. More recently, it seems that a lot of the susceptibility to severe COVID is mediated by differences in the innate immune system. So things like natural killer cell depletion, a propensity for pro-inflammatory cytokine release, unchecked activation of the complement system. These have all been described in schizophrenia. Whether they underlie increased risk of COVID mortality in patients with schizophrenia after COVID infection is still an outstanding question. And then there's the role of pathogenic antibodies, which are becoming increasingly understood. These include things like interferon antibodies, which were found in 10% of patients with severe COVID and hadn't really been described before. These were clinically silent antibodies that were interfering with the early immune response to viral infection and contributing to severe disease. Whether these are higher in schizophrenia or not, we don't know yet because it hasn't been looked at. But this is one of the things that we are looking at moving forward. And so some of the work that I'm involved in now is assessing autoantibody profiles in patients with schizophrenia compared to healthy controls. And because of technological advances, we're able to look at this in a way that we've never been able to before, looking at antibodies to tissues that we've never been able to detect before. We're also looking at immune responses to vaccination to see if there might be a difference in the timing or magnitude of antibody responses in people with schizophrenia compared to controls. And this might have practical implications for optimizing vaccine strategy in this group, but it also might help us understand immune responses that underlie susceptibility to severe infection. So here are just some of the take-home points. Schizophrenia is associated with increased risk of COVID mortality. This increased risk is not explained by medical comorbidity or antipsychotic use. It's possible that immune dysregulation explains this increased risk. And psychotropic meds might influence risk of infection and mortality through a variety of mechanisms. Again, I really think that the future is bright for us here. On the one hand, this has been a pretty devastating time for patients with severe mental illness, given their increased risk of mortality and the social isolation that came with the pandemic, their disruption to their normal psychiatric services, and now psychiatry is dealing with all of the psychological sequelae of the pandemic. But I also think that there's been some major wins here that should be acknowledged. These patients are now getting priority group status that's recognized by the CDC. There's been policy changes that have been made because of this. There's been more efforts focused on vaccinating these people and decreasing barriers to care. There's more funding for interdisciplinary research in this area to explain these findings. And I think this is really going to lead to some translational research that might really improve our care of this population as well as our understanding of the disease. Okay, thank you. I'd be happy to take any questions.
Well, thank you. Thank you so much, Katlyn, for a wonderful and fascinating talk. Just a reminder, if you have questions for Dr. Nemani, please type them in the chat function. So we have a few already. The first one is, the questioner is curious about the role of smoking rate in helping explain this relationship, and that simply controlling for smoking status, yes or no, may not be sufficient to really get at this, since we know that patients with serious mental illness not only are more likely to be smokers, but they smoke much more. They're more heavily than smokers with non-serious mental illness. So the question is, could it be a combination of heavy smoking and impaired lung functioning leading to increased vulnerability to respiratory death as a result of COVID?
Yeah, so we looked at this in our first study, which included not only patients with schizophrenia, but patients from the general population. And we did look at amount of cigarettes smoked per day to see if there was a difference in the, say a heavy smoker compared to a light smoker. We didn't see major differences. What we are seeing is that there is definitely an increase in risk related to smoking related diseases. So, things like COPD and obstructive lung disease are associated with worse outcomes. For some reason, what we're seeing is that these lung diseases seem to be more common in former smokers as opposed to current smokers. And I don't know that this is like fully understood, but it's something that we're seeing across epidemiologic studies. And, this could relate to this ACE2 problem. So with smoking, ACE2 tends to be upregulated, and it was initially thought that this upregulation would give the virus more potential gates for entry. But ACE2 also has an anti-inflammatory effect, and it counteracts angiotensin 2, which is pro-inflammatory. So is it better to have more ACE2 to spare because it's going to get knocked out when you get infected? Or is it better to have lower ACE2 so you're not at risk of getting the virus at all? I think it's sort of an outstanding question, and how smoking relates to that is still a question too.
Okay, thank you. Another question is, did you differentiate between bipolar 1 and bipolar 2, or the presence or absence of psychosis in your study?
Yeah, thank you for asking that. So in the study where we looked at antipsychotic use, which was limited to patients with severe mental illness, we only included patients with bipolar 1. And in the Office of Mental Health study, this was also only patients with bipolar 1. Patients with like a less severe psychiatric disorder like bipolar 2 are mostly not represented in that system. In that first study, we actually ended up grouping patients with a variety of mood disorders into one group, including patients with depression, bipolar 1, bipolar 2, because we didn't have enough patients to look at these groups separately. If that answers your question.
Yes, a fellow neuropsychiatrist said, yes, you did. I had a question.
Oh, it's Beth. Hi, Beth.
I had a question about your findings related to clozapine and the virus and the vaccine. Do you know if this has resulted in changes, particularly in the state hospital systems, about how closely people are getting monitored who are on clozapine?
So it's a good question. I've asked about this a couple of times. The vaccines were rolled out in January 2021. Is that right?
2021 for the healthcare workers in January. Yeah.
Yeah, and across the state system, it was actually like a surprisingly successful vaccination campaign. I think like 70% of the inpatients actually accepted vaccination, and at that time, I don't think increased clozapine levels after vaccination were on anyone's radar. There is a protocol now to monitor clozapine levels for patients who are prescribed Paxlovid. And, they sent out this whole checklist of who's appropriate for Paxlovid and how to monitor clozapine levels. When I've asked doctors across a few different facilities how they're managing this and if they're getting their clozapine levels back in time, they tell me that they've never seen a patient on Paxlovid, so it sounds like they're not really prescribing it. And it seems like even though reinfections are common, patients are not really getting very sick the second time around for the most part. Seeing very few patients that require transfer for medical treatment now. And whether that's because of pre-existing immunity or vaccination or whatever, I'm not sure, but yeah, clozapine levels.
Yeah, and I know we've had some case reports in the Journal of Clinical Psychopharmacology also of effects on the white count in schizophrenic patients who are on clozapine and get a vaccine or get infected too. And I can't remember. I remember there are reports the white count going either direction sometimes. So I guess that needs monitoring as well closely when even when somebody's getting vaccinated, it sounds like.
Yeah, and it's also been suggested that you can, rather than waiting for the clozapine level, you can check a CRP when someone's getting vaccinated if you're concerned, because if that is elevated, then that would tend to suggest that their clozapine levels might be going up too, and it's faster to get that back than the clozapine level.
Right. That's a good point. I have another question about or comment that the increase in mortality for patients on Depakote is not surprising, especially since it can lower white blood cell counts and neutrophil counts. Is it possible to replicate that in other data sets? And it says the absence of such an association for clozapine is the surprising finding.
Let me see. Is it possible to replicate this finding in other data sets? For sure. This type of observational research using medical records is easy, whether you're going to have a white blood cell count or an ANC available to compare among Depakote treated patients compared to those who aren't in the setting of infection is another question. But it's a little bit, I don't know if this observation has been made by other researchers who are hesitant to publish this, or if it hasn't been looked at, or if it just really hasn't been observed. Because if you look this up, everyone is talking about the potential for Depakote to really help in the prevention and treatment of COVID. And there haven't been many studies showing any protective benefit, despite all of the chatter about this theoretically having a protective association. But I think it really should be looked at.
Well, thank you. We're getting close to 1 o'clock, so I don't see any further questions. Thank you so much for this very interesting and fascinating work that you're doing. It's really is having an impact on the whole country.
I don't know about that, but thank you.
Well, the CDC is the whole country.
Thankfully, the CDC is not the whole country, but I appreciate that. Thank you.